Okay, thank you very much. The role of endoscopy in hepatobiliary and pancreatic disease for diagnosis and management is crucial and very important. I will focus on the role of male ERCP and EUS in treatment and management of and diagnosis of four categories of biliopancreatic cancers: the intrahepatic or perihilar cholangiocarcinoma, the CBD cancer, the head of pancreas or pancreatic cancer, and the ompeloma. Cholangiocarcinoma is divided into two subgroups: distal cholangiocarcinoma and perihilar cholangiocarcinoma. Perihilar cholangiocarcinoma represents a second most common primary malignancy in the liver, increase in incidence in the last years. A curative tumor resection, unfortunately, is possible only in less than 1/3 of cases, and best result with distal CBD tumors completely excised up to 40%. Patients with irresectable perihilar cholangiocarcinoma have a limited prognosis with median survival times less than 1 year with very poor quality of life. So this is the main role of endoscopy. First, to confirm the diagnosis. It's not always easy to diagnose cholangiocarcinoma, even when we have advanced endoscopy. Then endoscopy treatment aims to ensure adequate drainage of the biliary system by placing biliary stents, metallic or plastic, and it's mainly a part of palliative therapy concept to improve quality of life for patient and to reduce risk of obstructive cholangitis and its consequences. And there's a promising role now in intraductal tumor ablation or therapy. So before doing any management of for perihilar or cholangiocarcinoma, it's necessary to have a good preoperative staging of perihilar cholangiocarcinoma with combined new techniques of imaging, CT scan, MRI, for vascular extension that may optimize the result of the management. 80% of these are unresectable, and a risk of recurrence is high even in those underwent resection or surgery. As common malignant cause of biliary structure is cholangiocarcinoma, cytology can be crucial in early stages of malignancy when the radiology may have limited roles. So what is the first role of the endoscopy is to have a good drainage in the biliary system. And this is a paper from Lancet published in October 2018 about the comparison between endoscopic approach and percutaneous radiological approach in draining bile system. So endoscopy versus percutaneous biliary drainage, and specifically for potentially resectable perihilar cholangiocarcinoma. A systemic review, a meta-analysis. The radiological approach was better in overall post-drainage complications and less pancreatitis versus ERCP or versus endoscopic approach, whereas endoscopic approach is superior to PTC or PTBD when it comes to hospital length of stay. For global overall outcome, the radiological approach was better, superior to endoscopic approach in terms of clinical success and post-drainage cholangitis. If we decide to do endoscopy or ERCP for palliation, which stent is the best? Self-expandable stent were developed larger diameter as up to 30 French or for 1 centimeter with easier passage across the biliary structure. SAMs were superior to those of plastic stent for distal biliary obstruction with a patency per month up to 12 months versus 4 months in plastic stents. The decrease with metallic stent, we can decrease the number of repeated ERCP and the cost, and gastrointestinal endoscopy guidelines recommend the insertion of SAMs in 1 centimeter in diameter in patients with established diagnosis of malignancy as a prime stent, whether expected survival times more than 4 months, and the early complication is less than 5%. Now, what is a cholangioscope? You know well, and especially the surgeon who does the cholangiocarcinoma surgery, it's sometimes very difficult to assess and to diagnose or to differentiate between benign biliary stricture and malignant biliary stricture. And this is the role of peroral cholangioscope or spyglass scope. It can achieve or reach the bile duct, the common and the intrahepatic duct, through the channel of the duodenoscope. And through this operation, we can take biopsies and we can simply visualize the cancer. And this is a paper newly published regarding only the visual impression and the biopsy bites, and the result was in favor of only visual impression, was higher in diagnostic yield than target biopsies, probably because the bite of the biopsy is very small with the biopsy forceps, and they have to improve the quantity and the quality of the biopsy for pathological studies. The cost effectiveness of a spyglass procedure needs to be in count, so it's patient by patient. This is a new paper published 2020, retrospective study that included all patients who underwent spyglass for biliary stricture. And it was amazing that among 43 patients, only 24 was diagnosed, confirmed as cholangiocarcinoma or malignancy, and the rest of panel was only benign biliary stricture post-surgery, extrahepatic stenosis, primary sclerosing cholangitis, Caroli's disease, hypertensive biliopathy. So it's very important, this scope, to differentiate between benign or malignant strictures. Another indication, intraductal tumor therapy for perihilar cholangiocarcinoma. We can do local ablative therapy like intraluminal biliary brachytherapy that was the first described for this technique. Then photodynamic therapy and delivery of electromagnetic wave, the radio frequency, usually combined with systemic chemotherapy and or external beam radiotherapy, following by placement of nasobiliary tubes, each with metal tips or tips. A recent data regarding radiofrequency for perihilar cholangiocarcinoma is summary of comparative studies, two retrospective and two prospective, regarding the comparison between radiofrequency plus the metallic stent placement versus only metallic stent placement, and with systemic chemotherapy. The result in terms of stent patency was in favor of the group of radiofrequency plus stents versus stent alone. The survival per month was greater in the group of radiofrequency versus metallic stent, and less adverse events in the group of radiofrequency combined to metallic stent versus metallic stents. Now, the common bile duct cancer or distal bile duct obstruction, it is resemble a bit the treatment and the management to the head of pancreatic tumor or cancer. The aim of endoscopy is to restore biliary drainage and biliary flow with the relief of jaundice and treating cholangitis. Biliary sphincterotomy is not necessary always for placement of a single plastic or metallic stent. Both plastic stents and metallic stent can be used. Plastic stents are relatively less expensive. However, the diameter of plastic stents is limited up to 12 French, and the patency rate is approximately 3 months. So we have to repeat the RSP after 3 months from the initial plastic stent placement. Patients who live more than 6 months are likely to benefit from metallic stents. Now for extrahepatic cholangiocarcinoma, very, very, very interesting study published in last year in 2022. A very large number of patients, more than 2,100, regarding photodynamic therapy, radiofrequency, or stent alone. A total of 1,149 patients underwent treatment with photodynamic therapy, 545 with radiofrequency, and 452 with stent alone. The survival rate was in favor of photodynamic therapy versus radiofrequency versus stent alone, and the 30-day mortality was better in the group of less in the group of photodynamic therapy versus radiofrequency, and the pooled rate of 90-day mortality with photodynamic therapy was lesser than radiofrequency. What is the role of EUS in the preoperative evaluation of cholangiocarcinoma? This is a large single-center experience published a long time ago regarding sensitivity of EUS for the detection of tumor and the prediction of unresectability compared to CT scan and MRI. The detection was superior with EUS compared with triphasic CT, and the sensitivity of EUS FNA varies between 45% and 89%, and was significantly higher in the distal part of the CBD when we have a distal cholangiocarcinoma. But the pre-operative assessment for resectability was better with angio CT scan versus EUS. The EUS can help when ERCP fails. We can function directly through the lumen of the EUS scope. We can dilate and put stent to assume or to have a good biliary drainage, like I said, if ERCP fails. Endoscopic ultrasound guided biliary drainage in cholangiocarcinoma, hepaticogastrostomy, the technical success was very high, 98%, with the compromise of, unfortunately, high numbers of complications: pneumoperitoneum, coliperitoneum infection, and stent dysfunction or dislocation. Choledochoduodenostomy, overall success is lesser, but a bit less rate of complications. For the pancreas, EUS play an essential role, and it is a gold standard with high sensitivity for the detection of pancreatic tumor, and sometimes with small tumor less than 1 centimeter, with a rate of the diagnostic yield up to 90%. EUS tissue acquisition for pancreas, facility of EUS to obtain tissue specimens from suspected pancreatic neoplasm with high diagnostic yield. EUS guided biliary drainage, again, when ERCP failed, it could be an alternative. And when it comes to chronic pain, EUS helps a lot in celiac block or celiac plexus neurolysis. New technique promising for EUS to improve the yield of diagnosis, the contrast enhanced EUS and EUS contrast agents. New technique to guide radiotherapy and the placement of fiducial radiomarkers that can be used as reference to guide stereotactic body radiotherapy, radiation therapy, and we can deliver iodine to do a brachytherapy, and we can deliver ethanol, radiofrequency, chemotherapy, or biological agents to treat small cancers or neuroendocrine tumors. Finally, on biliary tumor, the endoscopy play an essential role and very important result when it comes to early on biliary cancer. This is a retrospective review of more than 170 patients underwent endoscopic papillectomy. Adenocarcinoma was present only in 28 resected specimens. In addition, an additional surgery was performed in cases of duodenal mucosal infiltration, duct ingrowth, or R1 resection or lymphovascular invasion. Some mucosal invasion was present in 16 among 28, and 9 cases present with lymphadenopathy metastasis. Endoscopic papillectomy is curative up to 100% in case of the monoblock with R0 resection and with no evidence of submucosal or lymphovascular invasions. This is a recently published Canadian article about more than 100 patients underwent this technique. Complete endoscopic resection was achieved in 82.5 at initial procedure. Only 11% has previously undiagnosed invasive carcinoma, Bleeding occurred in 21.4%, but manageable in the endoscopy unit. Acute pancreatitis was 15%, very high rate of pancreatitis, but was only mild pancreatitis in more than 90% of cases. Perforation occurred in 5.8%, all treated conservatively except for one requiring surgery. Piecemeal resection was associated with significantly higher recurrence rate compared to en-bloc resection. I will finish by the European Society of Gastrointestinal Endoscopy regarding recommendation for ampullary tumor. They are against and contraindicate this technique if the adenoma is not proven. Recommended endoscopic ultrasound and good MRI before resection. Papillectomy should be indicated in patients with ampullary adenoma without intraductal extension because of the good result regarding outcome, technical and clinical success, morbidity, and recurrence rate after resection. Block resection of ampullary adenoma or tumor up to 3 centimeters in diameter to achieve R0 for optimization, a complete resection rate. Considering surgical treatment if this technique is not available or not feasible by a good expert. Direct snare resection recommended without injection of products. Prophylactic pancreatic stent to prevent pancreatitis. And very, very important point, long-term monitoring of patient after endoscopic resection by doing a duodenoscope with sometimes artificial intelligence or high-definition scope with biopsy of scar and of any abnormal area within the first 3 months, 6 months, 12 months, and yearly up to 5 years post-resection. So in summary, EUS and ERCP are the mainstays of interventional endoscopy practice. ERCP plays an essential role, especially in indeterminate biliary strictures and in treating symptomatic patient with malignant biliary obstruction with borderline resectability or unresectable cases. ERCP direct ablative therapy promising, enable neoadjuvant and palliative intervention in patients with malignant biliary stricture or obstruction, in particular perihilar cholangiocarcinoma. EUS occupies a central role in the diagnosis of pancreaticobiliary neoplasm and offer a platform for a wide range of direct tumor therapy. Thank you very much.